Moving on to classification of articulators. Articulators are classified based on the theories of occlusion, and by the, the various classifications were given by Gillies, Boucher, Kingray, Beck, Weinberg, Werstom and Posselt. The most commonly used classification was given by the International Workshop at University of Michigan by the American College of Prosthodontists in the year 1972. According to this, there are 4 classes of articulators. Class 1 are simple holding instruments which are capable of accepting single static registration allowing only vertical movement, and they cannot accept baseboard transfer. Examples are Garriott's articulator, barn door hinge articulator. Class 2 articulators are instruments that permit horizontal as well as vertical motion but do not orient the motion to the temporomandibular joint. Even these articulators, cannot accept baseboard transfer. Example is mean value articulator. Class 3 are instruments that simulate condylar pathways by using average or mechanical equivalence for all or part of the motion. These instruments allow for joint orientation of the cast via the baseboard transfer. Class 3 are further subgrouped into Archon or non-Archon articulators. This classification of Archon or non-Archon was given by Bergstrom. R stands for articulator and CON for condyle. Archon articulators are those which exactly simulate human mandible, wherein the condyle is in the lower jaw and condylar guides or glenoid fossa is in the upper jaw or maxilla. Non-Archon articulators are the reverse or opposite of human mandible, wherein the condylar element is in the upper member and the condylar guide is in the lower member. Class 3 articulator maintains the same anatomic design by condylar analogues in the mandibular element and fossa in the upper element. Example is Hanow articulator and Whipmix articulator. Non-Archon, as I told you before, consists of condylar element in the upper and glenoid fossa or condylar guide in the lower one. Example is Dentatus articulator. Coming on to the Rilani's classification, he classified articulators as non-adjustable, semi-adjustable and fully adjustable. Non-adjustable articulators are simple holding instruments capable of accepting only static registrations, only hinge motion or vertical opening closing movements are possible. Semi-adjustable articulators simulate the condylar pathways by using average or mechanical equivalence. These instruments allow orientation of the cast with the help of a baseboard. Fully adjustable articulators accept 3-dimensional registration. These instruments also permit the use of baseboards. With these fully adjustable articulators, use of kinematic baseboard is possible and the incisal guides can also be customized. This is a picture which shows you the mean value articulator, which is the most commonly followed articulator. The parts of mean value articulator are, this is the upper member, this is the lower member, and we have the incisal rod with the incisal pin. This is the incisal guidance table. We have this is the part which represents the condylar element, and then we have the occlusal plane indicator, and this rod is used for stabilizing, preventing the upper member to fall down while articulation is being done. Recent advances, we have virtual articulators, wherein virtual reality is a computer based technology linked with future of dentistry and dental practice. Now these articulators reduce the limitations of mechanical articulators, and simulation is possible in real time with the real time patient database. Functioning of virtual articulators, it generates an animation of mandibular movements based on the input data and calculates the point of occlusion, which in turn are shown as on the computer screen by means of some type of code. The advantages of virtual articulators are it provides the best quality of communication between the dentist and the technician, simulation in the real-time patient database is possible, analysis of both static and dynamic movements is possible, analysis of gnathic and joint conditions is facilitated, and it acts as a 3D navigator. The limitations of virtual articulators, however, are it is expensive, it requires digital scanners, sensors, softwares, different types of virtual articulator models mimicking the mechanical ones according to the patient needs is required, and the operator or the technician must have sufficient knowledge about the CAD/CAM technology and the mechanical articulators. Designing, modeling of virtual articulators and technical skills is required for interpretation of the data from the scanners, sensors, and if at all any minor adjustments has to be made.